Alright, we're going to go over the last few little miscellaneous drugs that we have not covered so far in the respiratory medications. So the first one, the one you might have been wondering about, we talked about it yet, oxygen administration. This one is the most common administered medication in your respiratory emergencies. And a lot of people get kind of comfortable with it and just forget that it's a medicine, but remember that it is a medication and that we need to make sure that we are giving it only when appropriate to that patient. Okay, so oxygen is going to work by increasing the inspired percentage of oxygen, increasing the oxygen concentration at the alveolar level, increasing your arterial oxygenation levels, and increasing the amount of oxygen delivered to the cells. So it's going to correct your hypoxia and help reduce the volume of ventilation necessary to oxygenate the blood. And hopefully it's going to also reduce that myocardial workload to maintain a given arterial oxygenation levels. There aren't any absolute contraindications in medication or in oxygen administration, but we know that studies have shown that high levels of oxygen can actually be toxic and can cause problems within the body like vasoconstriction. So we want to make sure that we're treating hypoxia. We're only given enough to maintain that patient in the normal oxygen range, and we're not trying to hyper-oxygenate them the vast majority of the time. All right, so our main patients that we want to be careful with are premature infants and patients who are prone to carbon dioxide retention, who run off of a hypoxic drive. I'm not saying don't give them oxygen. Give them oxygen if they need it, but don't give them all the oxygen if they don't need all of the oxygen. All right, the most common pre-hospital devices you'll see will be a nasal cannula. This, is going to be 1 to 6 liters per minute, and the delivery is going to deliver concentrations about 24 to 44%. Your simple face mask is going to deliver concentration of 40 to 60%, running on 8 to 12 liters. Make sure you don't run less than 6 liters per minute through that device, because then you're going to accumulate carbon dioxide in the mask. You're going to have a non-rebreather, which will give 80 to 100% oxygen concentration, and make sure you're not running less than 8 liters per minute of oxygen through that. But typically we're going to run that at 12 to 15, occasionally 10, but usually 12 to 15 liters per minute. And then the Venturi mask. Now with the Venturi, it's not super common, but it's coming around some. But it's used a lot with like your COPD patients, and it's going to be very precise in delivering set amounts of oxygenation, where the patient may need more than ambient air, but doesn't need necessarily 75, 80, 100% of oxygen. So it's a pretty good thing when you have access to it. Now, all of these things are going to provide your oxygen, but they are not going to work on the ventilation. So make sure that if they need the ventilatory assistance, that we're looking at a CPAP, a BiPAP, or positive pressure ventilation, something like that as well. Now, as far as your antihistamines, these are used to block your histamine effects and reduce the allergic reaction symptoms, which is one of the things in the respiratory treatment algorithms. All right, they can cause some drowsiness, and there's a lot of different routes. With these antihistamine drugs, we're using them to block primarily your H1, your histamine 1 receptor sites. And these, while they're usually given orally, we do have a few that we can give parenteral, like your diphenhydramine or your promethazine. Those are going to be your first generation antihistamines. And what they're going to do is they're going to interact with your peripheral and your central histamine receptor sites, and they are going to have a pretty wide range of therapeutic responses, but they also are going to cause some sedation along with the relief of those allergic reaction symptoms. And this is the drugs themselves have a kind of an anesthetic and an anticholinergic activity, which is going to depress that sensory nerve activity, which is what's going to relieve the itching and the pain associated with your allergic reactions. Now, your second generation of antihistamines, that's going to be like your Zyrtec, your Allegra, your Claritin, things like that. They are selective as well for your H1, your peripheral H1s instead of your central, so they are not sedating, and they don't dry you out as much as your first generation medications there. Now, there are primarily histamine 2 blockers as well, but those are usually more for the ulcer diseases, peptic ulcers, because blocking the H2 receptor is going to decrease your gastric acid secretion. but it will affect the peripheral blood vessels just a little bit, but usually it won't reverse the vasodilation associated with anaphylaxis as much as your first line, your first generation antihistamines will. But these would be like a Tagamet or a Zantac or something like that. And those can be given orally and IV as well. Now, your leukotriene inhibitor drugs, what this does is it interferes with the formation of the prostaglandin derivatives that are the leukotrienes. And those are the things that cause the bronchoconstriction, the mucus production, the inflammatory response in the lungs. Your primary drug here that you might see in a pre-hospital setting is going to be Monteclast or Singulair. And this is going to be a take-at-home medicine. It's not something you're going to give in the pre-hospital setting, but it's something that they're going to take daily for chronic treatment of asthma. So diphenhydramine, your prototype here, it's a histamine 1 blocker. It will work on the peripheral and the central histamine receptor sites. And it does have some anticholinergic properties. Onset's pretty fast. We're usually going to give it IV or IM, 25 to 50 milligrams. There are no contraindications in the emergency setting. Our indications are going to be an allergic reaction, anaphylactic reaction. You also will give this in the dystonic reaction, which is where somebody has the EPS, the extrapyramidal symptoms, secondary to an antipsychotic medication, Haldol or something like that. And we also can give this for sedation if you don't have anything else. And it also works a little bit for motion sickness, although not as well as Dramamine does. And your precautions. Be careful with your asthmatic patients because this can thicken your mucus and your secretions. It also can affect and cause an increase in your narrow angle glaucoma patients. And it also can cause problems if your patient has benign prostatic hypertrophy. Now with that, this is in a non-emergency situation. So in an emergency situation, you really don't have any absolute contraindications. But if you were not sure, contact med control. Your side effects, we all know what the side effects of diphenhydramine are: drowsiness, dizziness, headache, fatigue, all those kind of things. All right. Now, as far as interactions, it is incompatible with Lasix. You cannot give it in the same IV that you are giving Lasix. So the last one, mag sulfate, and this is the same mag sulfate that you use in the cardiac patients. This is the same mag sulfate that you use in your preeclamptic patients or eclamptic patients. What changes is the dose and why we are giving it. So the indication, the onset, the peak, all that's the same, but it's going to act as a physiological calcium channel blocker. Our indications are going to be for severe refractory bronchospasm. Now, typically, pre-hospital protocols are going to indicate that you need to try albuterol or ipratropium, pretty much all of your other medications first before you try mag sulfate. This is kind of like the last-ditch effort, if you will, pre-hospital typically. Your contraindications: patients who are in shock, persistent severe hypertension, if they have a 3rd degree or 2nd degree AV block. If they're undergoing dialysis, because you can really upset their blood levels here, or if they have a known decreased calcium level. All right. Some books will tell you 40 milligrams per kilogram with a max of 2 grams over 10 to 15 minutes IV. Some books will say just a straight 1 to 2 grams over 10 to 15 minutes IV. But you're going to take this, so it would be 2 to 4 milliliters of a 50% solution, mix that in a 100 ml bag of D5W, and administer that over that 10 to 15 minutes. And what it's going to do, hopefully, is going to minimize and lessen that bronchospasm, because it's going to act as a smooth muscle relaxant in this situation. Now, your precautions: give it slowly, okay, because there are some nasty side effects, and make sure that you are monitoring continuously with your EKGs. They, with toxicity, they can get there fairly quick. And what you will have is a development of hypotension, and then you'll lose your deep tendon reflexes, and then they'll get kind of out of it and slurred speech, and then eventually they'll stop breathing, and then they'll die. So we don't want that. So treatment: if they see it, stop the mag drip. You're going to give calcium gluconate 1 gram IV if they're about to stop breathing or if they have stopped breathing, and then we're going to support that respiratory effort. Now, beyond them trying to die on you, your side effects: dysrhythmias, hypotension, hypothermia, itching and a rash, flushing, which is very common, make them feel really, really hot. They'll sweat a bunch. It can cause bradycardia, drowsiness, and respiratory depression. So like I said, it has some nasty side effects. So monitor very closely if you are giving this. Now, as far as interactions, it can cause those cardiac conduction abnormalities if given with DIG. So if the patient takes home DIG, you may want to consider calling med control before you administer this medication.